Committee for the IASLC, and I'm from Hofstra North Shore University in New York, and I co-chair with Professor Roy Herbst from Yale University from the U.S. And we're here today for an extremely important topic, which is some very exciting news on progress in screening for the early detection of lung cancer, which, as you'll hear, can have a major impact for all of our populations. I'd like now to have everyone around the table introduce themselves before we get on with the rest of the formal program. At the Communications Committee, we endeavor to make it easier to be able to work with the press and to be able to get the messages out that are so important in these difficult diseases of lung cancer and mesothelioma. Could you start, please, and introduce yourself?
I'm Dr Baldwin from National Cancer Center, Tokyo, Japan, and my background is cancer epidemiology.
I'm Jesper Petersen. I'm a thoracic surgeon from Copenhagen in Denmark. I'm PI of the Danish lung cancer screening trial, and I'm also chairman of the surgical subgroup working with surgeons from Europe and US and Japan on this issue.
Thank you. My name is Jim Mulshine. I'm a medical oncologist from Rush University in Chicago, Illinois. I have a long-term interest in early detection, especially in early detection using CT for management of curative lung cancer.
Hello, my name is Roy Herbst from Yale University, and I'm the co-chairman of the Communications Committee and a medical oncologist.
Please.
Hi, I'm David Baldwin. I'm a pulmonologist, or chest physician as we call them in the UK, from Nottingham University Hospitals, and I lead the lung cancer service there. And I'm the lead respiratory physician on the United Kingdom CT screening trial that's just been started in the pilot phase.
I'm Professor John Field from the University of Liverpool. I have a clinical chair in the University of Molecular Oncology. I am the chair of the International Association Study of Lung Cancer Early Detection Prevention Group, and I have also led the task group on CT screening. And I am the PI for the UK lung cancer screening trial called UKLS.
I'm Denny Aberle. I'm a professor of radiology and bioengineering at UCLA. I am also the national principal investigator of the National Lung Screening Trial, which I co-led with my colleague who is not here, Dr. Christine Berg from the National Cancer Institute.
Well, I thank you, everyone, and I'd now like to introduce the president of the IASLC, who will chair this press conference, Dr. David Gendera.
Thanks, Dick and Roy. I'm David Gendera. I'm a professor of medicine at the University of California, Davis, and as Dick mentioned, I'm the president of the International Association for the Study of Lung Cancer. I'm very happy to see all of you here today. I've been associated with many press conferences over my career, and I cannot think of a more important one than the one today. It's highly appropriate that this press conference regarding the results of this screening trial and the consensus statement from ISLC be associated with this World Conference. ISLC is the only organization worldwide which is dedicated to the early diagnosis, prevention, and treatment of lung cancer. This World Conference is by far the biggest medical meeting on lung cancer ever held in the world, with approximately 7,000 participants from over 100 countries. So this reflects well on the fact that the lung cancer epidemic is a global epidemic. And this international association is really the best suited to make commentary regarding the important trial results that we'll hear about in just a moment. I would like to emphasize that there has been, over the last 2 days, led by Dr. Field, a workshop that reflects the international participation in ISLC by experts from all over the world. And they have met for the last 2 days to formulate a consensus statement from our group regarding these results, with the participation of Chris Berg, who's the chief of the detection program, the early detection program at the National Cancer Institute, and Dr. Aberle, and led by Dr. Field. So what we're going to do is we're going to have some statements from Dr. Aberle and Dr. Field, and then we will open the press conference to questions. Dr. Aberle will give us a bit of a background and show a few slides regarding the trial, just to familiarize yourself with it. As you know, this trial just published in the prestigious journal, the New England Journal of Medicine. So, Denny?
Thank you. First slide. So, to give a bit of background about the trial for those of you who may not be familiar with it, the National Lung Screening Trial was a randomized controlled trial that involved 53,454 individuals who, by virtue of their age and smoking histories, were at high risk for lung cancer. These individuals were randomized to receive either CT screening or chest X-ray screening once annually for a total of 3 years. Participant enrollment began in August of 2002, with accrual finishing early in 2004. The participants were thereafter followed with annual questionnaires about interval health histories, diagnoses, etc., for an average of about 6.5 years. In October of 2010, the Data and Safety Monitoring Board that oversaw this trial with us determined that there was sufficient evidence to publish or to go public with the results of the trial. So I'll be presenting those results. Next. What you see here is a slide demonstrating or showing the breakdown of what we found among participants. Over all of the 3 screening years, roughly 24% of the participants had positive screens in the chest X-ray arm. By positive screen, I mean that there was a finding, a nodule or some other abnormality that was potentially related to lung cancer. In the chest X-ray arm, there were just under 7% positive screens. So the positivity rate in the CT arm was higher. The table that you see shows the breakdown among patients who had positive screens, the percentage of those who had lung cancers and those who did not. And you will see that in both arms, a high proportion of individuals with positive screens did not ultimately have a diagnosis of lung cancer, over 95% in both arms. There were a higher number of lung cancers detected overall at all 3 screening time points using CT than with chest X-ray, and a greater proportion of those lung cancers were early stage, as well as a commensurate proportion fewer were late stage. Next. This is the mortality table and the data that was determined by the Data and Safety Monitoring Board to be conclusive. What this table shows is that there were, in the low-dose CT arm, 356 overall lung cancer deaths and 443 chest X-ray deaths, which, when related to the total number of individuals and what we call person years in the trial, represented a 20% relative mortality reduction. The chest X-ray arm, the control arm in the National Lung Screening Trial, included a chest X-ray, as opposed to the European trials in which there has only been usual care without any form of screening. We compared our results to the another ongoing trial in the United States called the Prostate, Lung, Colorectal, Ovarian Trial, in which chest X-ray screening is compared to no screening. And that trial has determined that there is not a significant mortality benefit from chest X-ray screening. I think that may be the last slide. Okay. Those are the major results of the trial.
Okay, John?
Well, in my opinion, this is actually an extremely extraordinary achievement, and probably is one of the most important publications in the last decade in lung cancer. And I would like to publicly congratulate both Dr. Berg and Dr. Denny Aberle and the NLS team for really a magnificent result. It has actually moved the lung cancer forward dramatically. If one considers what has happened in breast cancer, we would hope in the next 10 to 15 years to see a stage shift in lung cancer. And that changes the whole management of how we will look to the future of this disease. So we're moving into a completely new era in lung cancer. And it's how we take this forward. Therefore, my congratulations actually goes to the whole of the NLS team. I know it's a very large group of people that have been involved in it. And I've been fortunate to be asked to chair the ISLC task group. And we looked at where we will actually take screening in the future and how we will respond to the results. And we've produced a position statement which has been handed out. And this particular position statement was actually developed by the international members of the ISLC community, Japanese, European, Korea, and right across the States. And therefore we had opinions from a wide range of individuals in different specialties, different clinical specialties, and also in areas of what I would call experience in screening. And we feel that this is a wonderful result, and the issue now is the timing for implementation. It is the first study to demonstrate a significant decline in lung cancer deaths in a screening trial. However, there are a number of quality issues that we still need to look to. And we're fortunate that there are a number of other trials, and we're sitting here in Amsterdam, and in fact the Nelson study within the Netherlands is the other world largest randomized controlled study, which is CT against nothing. And this trial is actually run by Dr. Rob van Cleveren and his group, and there's about 6 other trial groups including the UKLS. And we have all actually learnt from the process of the last 10 years and learnt a great deal from the work from NLST. And we appreciate that there are quality measures that need to be dealt with before the recommendation is put forward to go forward to actually consider national screening programs. And these quality issues are concerned very much around identifying high-risk individuals, how we actually do undertake the quality of CT, such as volumetric analysis, but a very important issue of cost-effectiveness. And I can develop this if people have particular questions. But from my point of view, we are on the crest of a wave of an enormous change in lung cancer. Thank you.
Okay. Well, in a moment, we're going to open up for questions because we're sure that you have some. I think we need to perhaps preface this discussion with a point that we didn't emphasize, I think, because all of us know it so well, and that's by comparison to most other major cancers, cancer killers, that lung cancer is usually diagnosed at an advanced stage. And so this is quite in contrast to some other types of cancers. And at that advanced stage, usually when there is metastasis, stage 4, that treatment, although we're making tremendous strides, it is all palliative. There is no curative potential. So early diagnosis for lung cancer is, if anything, even more important than for some of the other cancers. The second thing I would like to emphasize is that there is a statement from the ISLC being released regarding the consensus from this workshop. And I would just like to read for you the bottom line from this statement, that it is now appropriate for heavy smokers ages 55 to 74, so that this matches the National Lung Screening Trial, to discuss lung cancer screening information with their physicians to assist them in deciding whether to undergo spiral CT screening. So with all the qualifications that Dr. Field just mentioned, I think that that is the take-home message, is that smokers who would be compatible with the groups in the trial should be talking to their physicians about CT screening. How that's all implemented, what centers they should go to, I think will be the basis for this panel discussion. And Dick, unless you want to take any other commentary, I think we'll open for questions.
I just want to make one other comment, and that part of the ISLC statement, which you will see, is that nothing is more important than smoking prevention and smoking cessation, and that is to be emphasized. This works in concert with smoking cessation, is the fact that we hope to link smoking cessation and prevention programs with the screening. So in no way should one get the idea that smoking has been made safe by this. It is not even close to correct. But we are extraordinarily grateful for having this additional tool that has been shown. And there are many issues that remain, and we're happy to take your questions now to go forward.
So are there questions? And we are recording here, so I know nobody likes to stand up and go to the microphone, but if you could, or please speak up so that we can get this in the recording.
I'm happy. Shall I start?
Thank you.
My name is Zosha Chesteka. I'm here for Medscape Oncology. I have two questions. Number one is if patients are being urged to go to doctors and talk to them about spiral CT, how available is spiral CT worldwide? And number two, I think Dr. Arbel, I think you said that 95% of the findings didn't turn out to be lung cancer. Could you discuss that a little bit, and what were they? Were these false positives, or were they nodules that you should worry about? Was it early stage? If you could discuss that, thank you.
So with respect to the first question, I think helical or spiral CT is readily available globally. I think that is a good thing, and it is also a potentially bad thing. The reason why I say that is that most of the risk and benefit that we saw within this controlled setting of a clinical trial at these experienced institutions needs to be translated in implementation for public screening or for population screening using standard methods that will preserve the quality of the images, the low radiation exposures that were administered to participants, the follow-up exams that were performed in patients with positive screens, and following the outcomes in order to ensure that we preserve the benefits and minimize the risks. So I think that's one of the major goals of this task force, is in fact to try to promote globally, working with other organizations, the kinds of guidelines that should be implemented for public policy. With respect to the second question, one of the negative aspects of CT screening in the instance of the NLST was the high false positivity rate. That positivity rate, or a positive screen, is defined, and each of the trials that have done lung cancer screening have defined what is a positive screen in different ways. I think there are a number of approaches that we can use to minimize the numbers overall of positive screens and to better discriminate between those individuals with nodules who may have lung cancer and those who do not. And again, part of the opportunity for this workshop will be to come up with those standardized guidelines for the interpretation of CT screens.
Yeah. If I could add, and I apologize, I have to leave because I have to be at another presentation, but I absolutely support what has been said. And in regard to what Dr. Aberle just spoke of, the crux of that is that, which I agree with, is that screening is not about taking the picture. It's about the entire process. And that's why ISLC is so relevant, because it is a multidisciplinary organization which includes all those types of professionals, at least most of the professionals that are involved in the refinement of this moving forward. And so it's working out the terms, as Denny Aberle just spoke about, because the Dutch trial that's ongoing approaches this with the benefit of 3 years of experience of the NLST in a different way, in which their false positivity rate, which was published in the New England Journal in 2009, Rob Van Claveren was the first author, is about 15%. And there are differences because they call things differently, but the wonderful news is they both get to the same place, and they both have the ability to consistently find early-stage disease fairly efficiently. But the ISLC, we're committed to keep working together to have the cross-disciplinary dialogues to continuously process improve so we get better and better, safer and safer, more economical in delivering this kind of service.
And I might just say that for each of the panelists, again, since we're recording, if you could just identify yourself. That was Dr. James Mulshine who just made the comment. Before we go to the next question, if I can just say, are there other comments from any of the panelists on the questions that were directed to Denny?
If I just may add the comment that we have had a workshop yesterday. In fact, we are looking to bring together an international group, and we were fortunate that, in fact, probably the majority of CT trialists internationally joined us for a full-day conference. And we are looking internationally of developing these guidelines, and the guidelines will, in fact, be undertaken in association with professional groups from Europe, the States, and from Asia. Therefore, we want to be inclusive in developing the guidelines, because we want to assist individual countries in helping them make the decisions of how to implement CT screening in the future.
Okay. Next question. Thank you.
Mitchell Zolier, Internal Medicine News. A two-part question. So in terms of the statement where it's talking about high-risk patients discussing with physicians about the need for them individually to undergo screening, could somebody address more specifically the kinds of issues to think about in making that decision? And then also the implications of the paper in terms of more of a public health, public policy. How does it relate to that for the time being?
So the first question is about the discussion with the physician. And Dr. Baldwin, do you want to start off on this one?
Yes. Thank you.
And identify yourself again.
David Baldwin. So the question is of great concern because I'm particularly concerned to make sure that this is offered to the right patients, that the patients that are most likely to benefit get that benefit. And as has already been mentioned, this is a delicate balance between the harms to both the body and the mind that can be done when you do screening programs. So, for example, if you tell somebody they're eligible for a screening program, in the proportion of patients, that will actually cause them significant psychological harm, which needs to be dealt with and has a cost associated with it. And then, of course, there are the issues of the positive screens that have to be looked at, and some of them have to have tests on a positive screen, even though they don't turn out to have cancer and therefore don't benefit from it. So that's the harm, which is the downside. The upside is that the NLST has shown a clear benefit in mortality, which in lung cancer, as we've heard, makes a really big difference because the survival is so low in lung cancer. So we look as if we have a good benefit to risk ratio. However, if patients that are not in the category where they have definite benefit because their risk of lung cancer is quite low, then they risk having these tests and actually getting more harm than benefit. So what we've done in the UK with this in mind, in the UK we have a different system. We have a National Health Service which is unlikely in the near future to provide a screening program, because it has to be shown to be cost effective, and it has to be shown to be cost effective in a population that's very similar to the UK. So our independent sector, the private sector, may choose to offer CT screening. So what we've done is we've produced a list of recommendations that should be followed if an independent sector organisation is considering providing CT screening. And just to say, those centre around, first of all, being referred to someone who really knows what they're talking about when they're screening patients, experts in the area, so they can correctly identify the risks that that patient has of developing lung cancer. So they've got to be in the high-risk group. They also have to make sure that the scans that they do are very similar to the scans that are done in the trial. So they offer low-dose radiation as opposed to standard dose radiation, which is almost 10 times more in terms of its damaging effect to the low-dose scans that are done. So that's another very important point. And then also that the patients themselves are fully informed about risks and benefits, so they can make a choice with their doctor, and they need to be informed in a way that they can understand things, so that the information that's given has to be very well worked out and in the same way as that was done in the screening trials. And also, they need to, part of that is about explaining that many more scans will show abnormalities that are actually not cancer than that show cancer. So they've got to be prepared for this other abnormality that needs some follow-up. I've already mentioned the relevant expertise, but this expertise has to be across the board. It has to be pulmonologists and radiologists, and access to surgeons that really know the best way to act on any abnormal results. And then, as well as all that, you've had a normal screen, you're still at high risk of lung cancer. You need to be warned of the warning symptoms of developing lung cancer. Patients should not be falsely reassured and then not present to their doctors as a result of having a CT scan. They must be informed of the risks, ongoing risks. That can be quite worrying for them, but it's a health measure, and of course at the same time strongly counselled against smoking.
Along that same line, as a treating physician, I might make some additional commentary, because Dr. Baldwin has mentioned the cautionary qualifiers. But let's take a step back here, and let's compare this to screening for breast cancer. There is potential physical and psychological harm in breast cancer screening. And many studies have shown that the benefits of screening outweigh those potential harms. Now, we are in the very early days of screening for lung cancer, and all the things that would be involved with making sure that this is done in an appropriate fashion, that follow-up is appropriate, and so forth, is incredibly important. But the message to patients about screening is a positive one. And I think we can't overemphasize that. Are there additional comments?
Yeah, I was, Roy Herbst from the United States, Yale. I was thinking the same thing. You know, we're going to hear a lot at this meeting about patients with advanced metastatic lung cancer and new therapies, targeted therapies. But I don't know if the group here is aware, but if someone has metastatic disease, the cure rate is essentially zero. So to find lung cancer early is clearly the best way to deal with this disease. And that's why this is such an extraordinary result. And again, with all the cautions, I do think in the United States, at least, we are going to see screening, especially since this is a study largely sponsored by our National Cancer Institute. Assuming the insurers pick this up, and the most important one, the CMS, the Medicare and Medicaid, I think this is something we're going to see, but with all the cautions. And that's what's so critical. It takes a team to treat a patient when you first diagnose them with cancer. It's going to take a team to prevent cancer in a patient, meaning the pulmonologist, the radiologist, and all the cautions that we heard. And not every site's going to be able to do that. And we heard this from Denny. They might all have a CT scanner, but they might not have the other people involved. And then, of course, as Dick said, smoking prevention is going to be so critical.
And make another quick comment is what the physician will have to know on the other side of that when the patient comes in is that this study can only answer the questions for the population that it looked at. So these are people with a 30-year, pack-year history of smoking. These are people aged 55 to 75. And the findings apply to that group. And there could be people simply afraid of lung cancer who are never smokers. And physicians will need to counsel them that actually they are not at a high risk and should not be routinely screened. So this sort of thing is the kind of area that will need to be done and need to be explained in that visit with the doctor. It's why the general physician will be the one seeing these patients the most often who will have this conversation, do I need to be screened or not? And as all my colleagues and Professor Mulshine said earlier, it's not just for one doctor. It's no good to take just the picture. Once the picture is done, what's the follow-up going to be? Are you going to get to the appropriate person and get the appropriate follow-up and understand that this is an ongoing process if you are in the risk group, that one screen alone is not enough. So there's a lot for the patient and the doctor to know and to talk about, and this should be able to be done in a good way. Not simply go in, get a screen, and disappear. That's exactly the wrong message. And so it is, all the comments that have been made come together.
So we will take additional questions, but I just want to say this question that you raised about the physician-patient interaction, how that's handled, the message that's given, what occurs there is probably the most cogent that we'll be addressing in this press conference. So I would like to have the opportunity for any of the other panel members to make comments about this.
Yeah, I'm Jesper Petersen. I'm the surgeon. I would like to comment also. I agree completely with what David Baldwin said, but I also think that if people say they want to have a CT screen after consultation with their doctor, I think it's extremely important that the place that does that screening and the follow-up is a multidisciplinary team, so that it's not in some small place that you don't have. You have to have a multidisciplinary team to do this work. And for the surgeons, this will be a very large challenge that they offer the correct treatment to these patients with very small cancers. And that's why the guidelines that we are working on for the surgical group, we hope also that will be implemented and then published so that there will be guidelines for the surgeons, because they will be the ones that will bear the brunt of they will be at risk because they will be operating on too many people without lung cancers if they're not very careful. So that's one of the risks that the surgeons will face. But I think that the message is not that you should not do this, but I think that you should do it with caution, and you should do it in a center that has the facilities to do it.
Perhaps I can, since this is an international panel and we are an international organization, the interpretation is likely to be different around the globe. We have Dr. Sobu from the National Cancer Center in Japan. Perhaps I can get you to comment about how you think this information will be interpreted in Japan.
So the picture of lung cancer is not the same in Western countries and Japan. We have a lot of adenocarcinoma, and we have a lot of cancers among non-smokers, actually. The rate of lung cancer among non-smokers is a little bit higher in Japan and Asian countries than compared to the Western and European countries. So the lung cancer among non-smokers is a big issue, but at this moment, the findings from this study should be strictly applied to a high-risk group, not directly applicable to the non-smokers, low-risk groups. So we have to be very careful for the expansion of the findings to other non-high-risk groups.
So Dr. Sobu also brings up an additional point that perhaps this trial or this statement doesn't address, but that's the growing concern for lung cancer in people who have never smoked. So obviously a CT screen is not appropriate for them, as was mentioned. So if we're having this press conference 10 years from now, what will we be talking about? And my guess is it will be a blood biomarker, and there may be several, one of which could be for this risk group, and another perhaps for patients who have a family history or some other predilection that would make us concerned about them. So I'll just put that on hold for the time being, but looking forward, I think that may be where we're headed. I'm sorry, you had another question.
Well, I just wanted to get back to the second question I posed, which nobody specifically addressed, which was the public health implications. And let me just expand this. So, Dr. Herbst, you were talking about CMS coverage, insurance coverage, and I'm wondering then if people from the IASLC statement panel believe that patients who fit the profile of the ones who were enrolled in the trial, would it be appropriate to now have the routine availability of screening for patients who fit that profile and who have had this discussion with their physicians?
Well, I have my own personal feeling, but I'm going to turn to John first to speak on behalf of the society.
Just rephrase your question again, because I want to try and make sure we're focusing on the right
So the question is, on a public health point of view, so in terms of, say, public or insurance funding for coverage of screening, would it be appropriate now to, for the types of patients who fit the profile of the ones who are enrolled in this trial, the ones who the statement is encouraging to have a discussion with their physicians about the appropriateness of screening, if it's decided that screening is appropriate, would it be proper to have public funding for that screening?
Each country has to decide how to take this forward on its own. So coming from the UK, I shouldn't actually say how the Americans fund their system any more than that probably the Americans would say how the NHS system should work. However, regardless of the funding system, the issue is who should actually go through CT screening at this time is really the question you're asking. And what we've put in this statement is that individuals with the same risk has been demonstrated within an LST would appear to be the one group that could be seriously considered. But there are a whole range of issues that have to be considered. Dr. Baldwin has given you about 6 or 7 of them. And therefore what we're looking at is a doctor-patient relationship where in fact the benefits and harms are identified. So just to say a patient is high risk, you know, it puts them in a category, but in fact is that patient at that time suitable decision to go through for CT screening. So if one is actually saying does one roll out CT screening at this time, the answer is no. If one is saying is CT screening suitable for certain high-risk groups, and the relationship, the interrelationship between the patient and the doctor, and the patient is fully aware of the benefits and harms, and then the decision to go forward, then one would say that is the correct decision. But then the next point is where this work is going to be undertaken. And one wants to ensure, and in fact Dr. Peterson from Denmark has actually made the point, has to be undertaken in centres where all of the expertise lies. So it shouldn't be undertaken in a centre where there is just, let's say, 1 or 2 specialties. There has to be radiology, there has to be pulmonology or respiratory medicine, good pathology, good surgery, and therefore you're looking at the multidisciplinary team. And this has been emphasized very much in our workshop, that in fact we're not looking at single decision, we're looking at multidisciplinary, and the future will be that these diagnostic clinics will probably involve individuals from a number of specialties. Regardless whatever decision is made, the GP or the doctor also has to discuss their smoking status with them. And one of the important issues is that we integrate smoking cessation with CT screening. So even if the patient goes through CT and there's nothing there, and then they have to be convinced that they should stop smoking immediately or assisted in that route. However, we also know there's a large ex-smoking population, and these individuals fall into the category that they've given up, and therefore CT high risk may be a way forward. And the category that in fact has just been mentioned is the non-smokers. And that is probably our next major challenge. And in fact we had a separate workshop, we're looking at biomarkers, and just to re-emphasize, We want biomarkers initially to assist us in what was called indeterminate nodules. So once a CT is taken and you've got a nodule of a size that is suspicious, but not suspicious enough to actually go forward into surgery, one would hope in time we'd have biomarkers that would help us in that decision making. But then there's going to be another generation of biomarkers where individuals have no obvious risk, such as the non-smokers, but through a serum or a blood marker, hopefully in time we will identify it. And that is the reason that the IASLC has put so much effort into these two particular workshops, and that is why we're building a strategy to actually take this forward probably over the next 5 years.
I would agree with that. I'll just say that at our hospital in the United States, the Yale Cancer Center, we've made the decision that we will start to screen patients who meet the criteria as discussed from the trial. And we're just one of a number of U.S. sites that went online with the release of this, including my former institution. I was at MD Anderson. So in the United States, this will be offered, and but with all the caveats discussed in very specialized centers that have the ability to discuss the risk. And I agree fully with the panel that someday it's not going to just be the risk as described in this trial, but it's going to be, as we heard from Dr. Pito this morning, other aspects of how much have you smoked, over how long, as well as the molecular studies. It'll include consultation with surgeons, pulmonologists, and expert follow-up. And then I think what some of the major specialty centers can also do is then collect that tissue. And that tissue can be subject to genomic analysis and to sequencing so that we can then in the future truly identify who's at the most risk. But what's going to happen as far as, I agree, the coverage by insurance, we don't know yet. Although this is a trial that met its primary endpoint in the U.S., so I think there'll be a great pressure in the United States for this to be covered. The price of this is going to be rather low, $300 or $400 per scan, at least at the hospitals that I've surveyed so far.
And if I can, just before we go to the next question, I'd like Dr. Aberle, as one of the co-chairs of the trial, to comment on this. And the issue brought up by Roy and John about where the screening is done and how it's done can't be overemphasized. I guess I would say this is the term we would say, you need the whole enchilada. So how do we know what center has the whole enchilada and where maybe it's only half an enchilada? So Denny, what kind of centers are going to be able to do this in the appropriate fashion? And do we need some sort of formal accreditation, or do we need, is there a laundry list of what you need to be able to do this?
I would say yes and yes. And by that I mean, yes, I think there is a laundry list of requirements that will that need to be established by an institution that wants to do CT screening, and that will likely evolve into a form of accreditation so that quality controls and quality assurance can be better guaranteed, just as we've seen with breast cancer screening. I wanted to return for a moment to the question about the implications for public policy. And I think, as all of us have said, the NLST can answer many questions, cannot answer all questions. One of the questions that we can answer is, within this trial, what is the cost effectiveness of screening? And that's an analysis that's ongoing and will hopefully be published at some point in the near future. I think cost effectiveness analyses will factor hugely into decision making by the purveyors of public policy with respect to how this is implemented and how it's actually covered.
I'd just like to make a quick statement. Richard Gralla from North Shore LIJ in New York. Basically, this, given that the appropriate studies are done to show cost effectiveness, because we do see effectiveness, and cost effectiveness simply means value, and if that is shown, then this is that would then be very consistent with evidence-based medicine. And if we are believers in evidence-based medicine, and if there is cost effectiveness in the countries, then it will be beholden on those countries and their insurers and their national systems. In the U.S., that's CMS, and that's private insurers, to go ahead and cover this for the proper groups. And again, I think that it will be very important that we watch to see that there is no hesitation in doing so, given that the proper studies go forward. We have effectiveness. Now, is there value to that effectiveness? And we've heard predictions that within 5 years we will have serum markers, etc. My prediction is that this will be shown to be not only cost-effective, but very cost-effective. That's simply prediction. We need the studies to verify that. And if so, going forward will be important. And these will be very costly programs within countries.
Okay, and perhaps we should move to the next question.
Susan Mayer from the British Medical Journal. I was going to ask about whether you collected cost-effectiveness data in the study, and you've already answered that. Could you just tell me what the major drivers of that equation will be? Just the big amounts, really, that other countries will then need to translate.
Yes, I think the major drivers, I mean, obviously the initiation of cost will accrue with CT screening, and in the proportion of patients with positive screens, the follow-up studies to determine the relative risk of that nodule being a lung cancer. The major costs of the screening will, however, not evolve from the screening exam itself, but will derive from the downstream diagnostic tests that are performed, as well as the treatments. And all of those are factored into what we call a formal cost-effectiveness analysis.
And I had another question. Could you just briefly summarize the other trials that are going on in this area, and could anybody say when they're likely to report back? And then will you all meet again to review your current statement?
John?
There are a number of trials in Europe, and as I've previously said, the major trial, in fact, is the Nelson with 20,000 individuals. And in fact, alongside that trial is the trial within Denmark, which Dr. Peterson is running. There are in fact, there are 3 trials within Italy. There's 1 within Germany, and in fact, I also mentioned we've launched the UKLS in the UK. We maybe come to this slightly late in the day, but we are there, and the important point is that the Europeans have been meeting probably for the last decade and actually looking at ways of pooling data, because some of us have smaller numbers, but then if you look at the whole of Europe, it could quite easily be 30 to 40,000 individuals. We actually had funding from the American Cancer Society back in the early 2000s, so therefore a lot of the protocols of radiology, pathology were brought together. And we've also gone for the same sort of minimal data sets. This enables us to actually undertake, the analysis will be done by each country separately, but the whole view is to undertake pooling. And thereby we will have a European number that is very similar to the States. But part of the ISLC is actually to bring together not just the European, the American, and also the Japanese data. That group has been invited to join, whereby if one looks in maybe 3-4 years' time, it's quite possible it could be up to 150,000 cases, the possibility. And we use a model of ILCO, which is a genetic epidemiology group, of bringing groups together and bringing data sets. And there's probably over 50 groups at the moment. And it's a very good model by Paolo Perfetta. But the point is that in Europe, we are awaiting outcome, and probably 2015 is the report date for the Nelson. They may consider doing an intermediate, but that's the decision of their own data monitoring committee of when they do it. So we are looking over probably the next 3 to 4 years for outcome from Europe. If I can just add your question about cost effectiveness, the UKLS trial were funded by the HTA, and that was one of the major questions, was the cost effectiveness. So not only demonstrate, in fact, that we have a major mortality advantage, but also the program is cost effective.
And the hour is late. We probably have time for one additional question, if there are any. Any other statements from the panel? Closing statements.
Just a last point. I want to emphasize that the ISLC intends to continue to have the dialogue on the screening continue among all these groups. So this is not just a one-time meeting, and this high-level panel that Dr. Field has put together will continue to meet. So please be assured that all these groups have been talking to each other and will continue to talk with each other.
Okay, thank you all very much. Excellent.
Great.
Excellent.
Great.
Would you like a little paper supporting?
Very nice.
My knees, I've been standing too much.